Hello, 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 and welcome to this evening's town hall. My name is Ethan. It is Wednesday, September 30th, 7:01 p.m. on the East Coast. As always, please come on in, say hello, let us know where you're from. We always like to give shout outs to everybody. We have an amazing panel tonight, so we're excited to dive right in. We always like to give it a couple minutes for people to come in. There is Molly. Molly's usually under Not Alone Notes. It could be Morgan, but I'm pretty certain it's Molly. So Not Alone Note says yay Mary. So yay Mary. We're excited to have Mary. Who else is out there? Let us know you're here. Say hello. Hey, there's Darcy giving Mary some love. Hey Darcy. I was correct. It is Molly. There's Yvonne. Hello Yvonne. How are you? It's kind of weird that I know where everyone's from asking for the last 6 months. Where's everyone from? Hi, Sam. Hi, Maya. Hi, Megan. Hi, Margaret. That's a lot of M's. Luis in Puerto Rico. Hello, Luis. So we'll just give it about 30 more seconds just to let people get in the door. Megan in New Hampshire. It's getting chilly up there, I think. Talia in Florida. I don't want to divulge John's exact location, but he's in Florida too. First time joining from Massachusetts. Hey, Andrea. Andrea? Is that correct? Andrea? Sue in New Orleans. And we are just at the 2-minute mark. So we have a lot to cover tonight, and we're really excited for this panel. So let's go ahead and dive right in. Welcome to the OCD ASD Town Hall Volume 2. It's called Volume 2 because, believe it or not, we had a Volume 1. So this would be the second in the series. Let me quickly go over just the quick housekeeping so we can dive right in. My name is Ethan. I'm the National Ambassador for the International OCD Foundation, which simply means, as I always say, I have OCD, and I like to talk about it way more than I probably should. This town hall is intended to serve as educational content and is not intended to replace therapy. For treatment-related questions, please be sure to work with your local provider or contact a local clinician. The National OCD Foundation is not a crisis hotline and should not be used if you are in distress or feel unsafe. If you are in a crisis or ever feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the Suicide Prevention Hotline at 800-273-8255, right below. We always want to be respectful and kind of others. We want to create as safe a space as possible. Always remember that this is a public forum. It is online, live stream, and will be online. So be aware of that as you ask personal questions. But again, we always try to create as safe and as supportive of a space as possible. Hi, Becky from Utah. So with that, let me introduce our panel, and then we can dive right in. So I think we'll start with Dr. Rebecca Sachs, just below me. She's a clinical psychologist specializing in the assessment and treatment of individuals on the autism spectrum with obsessive compulsive disorder and severe anxiety. She is board certified in behavioral and cognitive psychology and brings warmth, sensitivity, and a strong sense of humor to her work as a licensed clinical psychologist. She's excited to start a second venture, a school refusal program for students 6th grade and beyond. Dr. Sachs is currently seeing patients virtually in the state of New York. Thank you, Dr. Sachs, for being here.
Thank you. Nice to
I almost said for having me, and it was weird. But anyway, next we are very excited to have Mary Wilson. Mary is a college student in St. Louis, Missouri. She was diagnosed with OCD since she was 8 years old and began receiving effective ERP treatment at age 15. She's gone to every IOCDF conference since 2016 and has presented every year since 2017, which is awesome. She was first identified as autistic by her school in 6th grade and received a formal medical diagnosis at age 18, which is a long difference. Since her autism diagnosis, Mary has become a strong self-advocate and is dedicated to helping people learn about autism. Mary is planning on double majoring in psychology and creative writing with the eventual goal of getting her PhD in psychology. When she's not busy with schoolwork, Mary likes to cook and bake, take pictures of her 2 amazing dogs, watch Netflix, and talk to friends. Hi, Mary.
Hi. It was a long bio. I apologize.
No, it's great. Are you kidding? I'm curious. I'm sure everyone else is curious. What are you watching on Netflix right now?
I'm finishing up Jane the Virgin. I have like 3 episodes left, and I'm really sad because it's a good show.
I know you're invested. You know the characters. I know it's sad when it ends. Last but not least, we have Dr. Jon Hoffman. Jon is a licensed psychologist in Florida, New York, and Utah, and board certified in behavioral and cognitive psychology. Dr. Hoffman is chief clinical officer and co-founder at Neurobehavioral Institute in Weston, Florida, and co-founder of the NBI Ranch Residential Program in Southwest Ranches, Florida. His extensive experience diagnosing and treating obsessive compulsive and related disorders. Dr. Hoffman is on the scientific and clinical advisory board of the International OCD Foundation, is co-chair of its special interest groups on OCD and autism spectrum disorder, and is a faculty member for the Behavioral Therapy Training Institute. Among other publications, he is the author of the book Stuck: Understanding Asperger's Syndrome and Obsessive Compulsive Behaviors. Thank you, Jon.
Thank you.
And incidentally, lots of people love Jane the Virgin Mary, so you are in good company. All right, so let's get started. First off, let's start with some basics, just to cover, get our ducks in a row. So, Jon, what is the formal definition of autism? What is autism?
Well, autism is going to be a very broad definition because it's a very heterogeneous condition. But basically, the hallmarks of autism are difficulties and different mindedness in terms of communication, social expression, and what has to do most today is the propensity towards repetitive behaviors, and maybe even beyond that into OCD. I think it's important to remember that people, when we say autism, it covers an incredible range of people at different functional levels and different needs. And I would just also add that the level of autism, just like the level of OCD, is not necessarily equated with one's ability. You can have the categories of fairly mild autism and be very, very impaired from OCD. You can be more severe and less impaired. So when we're talking about the whole population of people with this combination of conditions, it covers a very, very wide swath. And I think that's important to keep in mind as we keep going.
Okay, thanks, Jon. I'm personally, I'll be the first to tell you, I am not as educated or learned in this particular subject. So I'm hoping to learn as much. So as I learned with substance use, if I say anything offensive, please correct me. I will try not to, but I may not know. So I'm going to learn along with everyone else and do the best I can to navigate, although I did do a bunch of research before this. So Rebecca, why is, well, first of all, how common is OCD and ASD as a comorbid issue?
Me, you're asking? I would say more common than we think. What we know is so there's no definitive research on it. What we've seen in studies is that it can range from anywhere from individuals who are autistic to maybe having OCD to somewhere around like 12% to even over 50%. So it really depends on the study, and it's a wide range. What we do know is that people on the autism spectrum are probably more likely to experience mental health conditions such as depression, anxiety, OCD, compared to a neurotypical individual. And so Valerie Gauss, who actually wrote the book Living Well on the Spectrum, she often says is, if you knew that penicillin worked for a neurotypical individual, why would you ever withhold penicillin if an autistic person had strep throat? And she makes that argument saying, if we know that CBT with exposure and response prevention works really well when treating OCD for a neurotypical person, why would we ever think to withhold that from a person with autism, especially if they're experiencing it at even higher rates? So just something to keep in mind.
Absolutely. We're going to circle back around. Also, I already see questions pouring in. Please feel free to load your questions in the comment section. We're probably going to talk for another 20 minutes, and then we'll go into questions. However, if I see anything specific, I'll try and call it out as we go. So, Mary, we're really excited to have you. People already have a bunch of questions for you. So I just want to start with, can you just tell us, I know I read some basics on your introduction, but tell us a little bit about yourself, where you've come from, where you are now, your personal story.
Okay. Well, to be literal, I'm from St. Louis. I'm in St. Louis. That was a bad joke, but I'm a college student. I am in community college right now, and it's taking me a little bit longer due to some health issues, but I'm set to transfer to a four-year university in the spring. I was supposed to transfer this semester, but COVID. And so I'm doing online school like so many other people. Everything is on Zoom now, which is either good or bad. I have, like I said, I've always displayed autistic tendencies, but they've become more pronounced when I entered puberty. And I'm not a scientist or expert or medical expert by any means, but from what I've read is that, let me mute the chat, that's distracting me, I'm sorry. That when social skills increase through the general population, they kind of stay the same or in autistic people. And so the gap is more pronounced. And so it's easier to blend in. And autistic girls can kind of mask really well, which is like, I can pass as neurotypical most of the time. And even if I can't, you might be like, oh, she's just quirky. And so it's, people just learn to copy. Where I am now, I don't really know how to answer that question. I work, my dream job is to be a like liaison between autistic individuals and their caregivers, their neurotypical caregivers, to try to sort of increase understanding and communication on both sides. And I've worked a lot with autistic individuals already. I've created a communication system for a young man who's non-speaking and was previously assumed unable to communicate. And so I'm really interested in like developing alternative ways and really working for like a acceptance-based approach versus a cure or fear-based approach. So that's a long-winded answer. Sorry, I didn't know how to answer that.
No, most of my answers are long-winded, and I usually start with bad jokes too. So you and I are best friends. Although your joke wasn't even bad. So I just want to say to people asking some great questions, I really want to stay on topic with OCD, ASD, although we'll always answer your OCD questions as well. But I just want to keep that in mind. I will throw back to Jon and Rebecca in just a second. But I'm curious, Mary, in your introduction, you said that you were diagnosed with OCD at 8.
Yes.
And then you were identified ASD in 8th grade. So,
yes.
So 2 questions. One is, when did you first notice OCD symptoms when you were a child? And then how did that compare to sort of noticing when the ASD was becoming present for you? Or did you notice?
So for me, OCD is like this intruder and this thing that I don't like, and it causes incredible fear and anxiety. And we all know this. That's the OCD Foundation. We know what OCD is, hopefully. But for me, autism I don't know any other way. It's a way of being. It's like the saying goes, like, when I go to the airport, like I don't check my autism with my other luggages. Like I can't separate my autism from myself. I know that a lot of doctors didn't even pick up on it because it's more, people are better at it now. But when 2005, 2006, when I was diagnosed with OCD, people weren't really familiar with autism. And people who weren't male toddlers who couldn't talk. Anyone who didn't fit the stereotype is like, oh, you're fine. And so I think, to circle back around your question, I don't know that I realized that I was autistic. I was just me. And I very specifically remember OCD coming on. I had just had a major surgery when I was in kindergarten. And after that, it was like, hello, OCD. And from what I've read, that can be sort of common with a trauma than a trigger to offset the OCD, and I have the genetic makeup for it, but autism is just kind of there. So I don't know if that answers your question or not.
No, I appreciate that. Rebecca's nodding her head, so let me throw this out. With OCD, we always talk about you are not your OCD. A lot of people identify as their OCD, especially before they become educated about OCD. From what I'm hearing from Mary, how is that different with ASD?
Asking me or?
Yeah, Rebecca.
Yeah, so I mean, Mary said a lot of amazing things.
No, feel free to piggyback on what Mary said. You don't have to listen to me.
No. So I may say, like, highlight 2 things that Mary said and then try to answer your question. So one awesome thing that Mary said is she talked about this idea of masking or social camouflage, how that a lot of autistic people, but especially like females, can sometimes with a great deal of like exertion or energy mask and sort of follow those social rules, but it doesn't feel as organic to them. One of the things that I want to say is, so I've worked with a lot of families that when I point this this out to the parents, parents often go, oh, that's great. I'm so glad my child can do that. And I say, no, hold on. What the research shows is we actually know that for people who do social camouflaging and masking, we typically see that there's a higher rate of depression and even suicidality. So what it lets us know is that there's something going on. It may be a correlation, or it may be that the exertion and sort of the energy that we need to put in to camouflage and mask is really, really sapping to an individual. So I just wanted to highlight that clinically, if people didn't know, because I thought that was a great point that Mary made. Mary also said, this has always been her. She doesn't know anything different. And I think it's great. One of the things to know about is autism is a lifelong condition. It's a thinking difference. Sometimes there are people out there who talk about cures for autism. I don't personally think autism needs to be cured. And I also know autism isn't cured. That's just not how it works. That's basically what I would say. So when you're saying what's the difference between autism and OCD, in some ways, it's just really how our brain works differently is autism. We process information differently, whereas I would say is OCD can not necessarily be that we're processing information differently. It can just be more that we're bringing attention to certain things in a non-functional way and then causing us to do behaviors that get in our way. Whereas with autism, sometimes those thinking differences can also be really huge strengths for an individual. I have to say, probably being a therapist who I've realized now that I've been, sort of sheltering in place and then social distancing, I probably spend more time with autistic people than neurotypical people since March. And what's really, really interesting is sometimes maybe thinking more like an autistic person. I actually think there have been a lot of benefits with like forcing myself to do certain things in the COVID pandemic that I've actually been able to leverage of probably having more insight into the autistic mind, about being able to have functional routines, even though in a non-COVID way, they would maybe seem non-functional. Just little things like that. So yeah, I'm rambling now, so I'll let Jon add in.
Well, I'll address, thanks, Rebecca. I'll address what he said in a way as well, that the classic difference has been in terms of autism, OCD within people with ASD. And Mary said for her, it feels like kind of an intruder, but not everybody with autism. In fact, many people with autism don't experience that as an intruder. It's actually a good prognostic sign for treatment when you experience something as being different than yourself. The problem
Mary
for
said
a lot
the
of
OCD.
people,
Mary said the OCD is an intruder, not the ASD.
No, I understand. She said, that's what I'm saying. She said maybe I misspoke. So said the OCD is the intruder, which is why it's what helps it be treatable. Since but the OCD, what I'm saying is that, and I'll try to be clear about it, that the OCD experienced by many people with ASD is not experienced as an intruder. It's just experienced as a different way of being. And that divides people who have ASD and OCD into kind of categories of treatability. To the extent that you experience the OCD as intrusive, you're going to want to get rid of it. A lot of people, however, it feels more gratifying than intrusive. It feels, even though it's OCD, it doesn't necessarily carry that same distress. Classically, they used to call this ego dystonic and ego syntonic. And that is one of the barriers. Actually, in treatment, we try to help somebody who has OCD, someone with ASD who has OCD, actually experience that as a bit different. And that's why education about this, and not just saying, all right, that's just the way somebody is actually important. But that's actually kind of an interesting line, because we don't want a person to feel bad or embarrassed in any way about their state of being, but some of the states of being actually work against being able to function. So that becomes the kind of subtlety of working with people in this community.
Can I add one asterisk to Jon's comment? Because I think he brings up a great point. one of the other things that I would put in there as the asterisk is this idea of family accommodation or even professional accommodation. That because of the repetitive behaviors, which often are what I would say is ego-syntonic for individuals who are autistic, or because of difficulties with ADLs, activities of daily living, like just hygiene, getting ourselves up, things that have to do with more independence, may often require, especially compared to where a person is in age, so more involvement by professional staff or more involvement for families. And so then when an autistic individual is experiencing OCD, it's often really hard for the other people in an autistic person's life to sort of disentangle themselves and not see, hey, what's helpful when I do accommodate or what's helpful when I do support and involve myself. They don't understand what they're actually doing is sort of exacerbating the OCD and increasing it. And I think that's part of also where this can get tricky, because we know is for people with OCD, when their family is accommodating their OCD, it doesn't often feel ego dystonic at that point because they're not having to feel that tension of the obsessions while resisting compulsions. So,
yeah, and that's why that's really an excellent point, and that's why it's so important that for family education, just like we try to talk with people who have ASD about OCD in a particular way and how it's impacting them. But I think for the families also, that sometimes, they see that the person, the family member, is kind of almost like enjoying the ritual things or repetitively doing things, whether it's something repeating dialogue or something turning on things and off things, and they are reluctant because it doesn't seem to be upsetting the person. It seems to be calming that down. It seems like it's something good when it's actually going to impede functioning in the long term. And I think this gets to, just to branch off even a little bit more, this gets into one of the other areas, is that often what is really OCD is mistaken as a talent or something that's going to help someone succeed in life, when it's really a perseveration, a splinter skill. And then disentangling that from something that's going to be an adaptive talent, even if it is that, to something that's actually going to wind up doing more harm than good is also. So I think what Rebecca and I are saying, and Mary as well, is that this area has a lot of different subtleties to consider. And that's what we're hoping to emphasize tonight.
Mary, do you have thoughts on anything that Rebecca or Jon has said?
Two thoughts, or many more thoughts actually. I'm full of thoughts, but I will limit myself to two. Because I don't want to talk
Mary,
to them.
not so.
Don't limit.
But
They never limit themselves to two thoughts, so feel free.
Not even a little bit.
What Rebecca said about masking and depression, I have experienced that. Like, it is the most exhausting thing to pretend to be neurotypical all day and come home and just like, it's like, you're done. It feels like you're burning out. And there's a lot of times it's been discussed more in scientific literature, which is new, in that autistic burnout is actually becoming like a recognized thing. And how sometimes in times of transition, or as autistic people get older, they've always been high functioning or so good at passing or almost normal, or just a little quirky. They will burn out, and sometimes they'll lose skill. We will lose skills that we have acquired. And it's a temporary regression, but it can be scary for other people. And like, oh my God, I thought you were so fine. Like, no, I was pretending this whole time. And that is correlated with depression. Every autistic person I've talked to, which obviously isn't every autistic person ever, has said like, yes, it is correlated to depression. Realizing that, people perceive your way of being, of acting, is wrong or different, and knowing that people actively try to change people like you through various therapies to make you indistinguishable from your peers, like that's some depression-causing stuff, to realize that you're broken, that people think you're broken. And even though they say, oh, I hate my child's autism, I don't hate my child. Well, like, but the average age of death for an autistic person, not to be too morbid this early in the evening, is 36. And the leading cause of death is suicide. And so something needs to change. And I think if people, that's a whole other story. But yeah, masking causes depression. Yeah, I recognize that. And thank you for bringing that up. it's validating to hear a professional say that. And what Jon was saying about how like, people don't realize that OCD is an intruder and families can have a hard time disentangling themselves. I was really lucky that I got somewhat of a prompt diagnosis for OCD. And even though I wasn't put in ERP, I was put in cognitive behavioral therapy. And I had this really amazing therapist right off the bat. And she was like, this is your OCD and this is you. They are different. Mm. And she had me like label worry bug. She like did lots of diagrams. And it made so much sense. And I think if we can explain to people, I know that myself and a lot of other autistic people are very literal thinkers, black and white. And so just saying, it takes a long time to it can take a long time for things to sink in. And I think that's true with anyone with OCD. When they get a new concept in therapy, it goes against what they want to do. So it takes a long time to sink in. Mm-hmm. And I think for people on the autism spectrum, it can take even longer. Which is not lack of intelligence, it's just a different way of processing. And for me, it helped. My parents were, before they knew that accommodating was bad, accommodating my OCD was bad and reassuring me, they did it all the time because that's what parents do. They want to help their children if they don't know what that's not supposed to do. They want to make their kid feel better. And so what helped me understand is when my therapist and my support group leader told my parents, you can't do this. Either Mary gets better or she doesn't, or you do this. And having it in those terms. And also I was at a point where like, it was either suicide or get better. And so I was like, okay, I guess I can't do it. And that helped having that black and white contrast. So I think having therapists and family members being like, family education and being like, I can't reassure you anymore. It's going to be hard. I still love you, but I can't do it because I love you. And just holding firm to that is the best thing to do. But yeah.
Mary, I want to ask you, so just looking at, you were officially medically diagnosed with ASD at 18, but it was suggested or first identified in 6th grade. The quick question is, which OCD or ASD did you personally identify with first? And then when you got the second diagnosis, well, I'll let you answer that first.
I think, can you repeat the question? I'm not sure I understand.
Like you got a formal diagnosis of OCD when you were 8? Mm-hmm. Is that right? And then, but you got a formal diagnosis of ASD at 18?
Yes.
So, but you were identified in 6th grade as being ASD?
Yes.
So for you yourself, those were around the same time. Did you consider yourself OCD first, or having OCD first, or having ASD first?
I didn't even know what autism really was. I had a lot of misinformation about it. Mm. And so I thought autism was the kid in the special ed class who couldn't talk, which autism can be that, but it's not always that. And so I think I was really lucky to have a family genetic OCD link, and that family knew what OCD was. And so even though I felt alone a lot of the time, I knew that it wasn't my fault that I had these thoughts. And then when I was first identified as autistic in 6th grade, I went through a really deep depression. That's what
I wanted to get to. I wanted to ask you, that's what I wanted to get to, is when you got that second diagnosis, in this case, it was ASD, what did you feel like did you feel like, oh my God, I have something else now I have to deal with? And like, my brain is even more screwed. Like, what was that experience like?
I was really sad and I hated myself. And I told my best friend, the only other autistic person I knew, I said, if I'm ever going to have kids, I need autism to be cured first, because there's no way I can pass this on. I can't do that to a kid, which is like heartbreaking to hear myself say now, but I was all for curing autism and faking it and just all the stuff, all the normalization therapies, because that's what I was being told, either through school. And my mom is amazing. She can hear me, she's in the other room, but I don't want to piss her off. But she was working as an ABA therapist, applied behavioral analysis therapist for autistic kindergartners in a full inclusion classroom. And she was told lies like autism leaves the shell of who a person would have been, and autism needs to be cured. And my sister was pregnant with her. My sister was much older than me, and she got pregnant. She was pregnant with the second kid by then. And she was like, I hope my son isn't autistic. I can't handle that. What if he is? Mm-hmm. And I'm hearing all this, and I've just been diagnosed, and I'm like, okay, then who am I? Like that, I must be broken. And I was raised Catholic. Say what you about Catholicism, but it has guilt. And
We're Jews. We have guilt too. We got it.
I was thinking that.
I know.
It's mutual guilt. I went to confession, which was like a big deal for Catholics. And I told a priest, I said, listen, I don't want to be autistic. If I pray hard enough, will my autism go away? Will I be okay? And he goes, yeah, just pray really hard and you'll be okay and your autism will go away. And like, that took a long time. All of that took a long time to overcome and really unlearn. And I still have a lot of internalized ableism. Ableism is like racism for disabled people. That's not a good explanation, but it's like, I don't know how to do words. But I have a lot of internalized hatred for autistic people, not towards other autistic people, but for myself. And over the years, between 12 and 18, I was like, okay, this is okay. And I became really fierce advocate. But then when I was formally diagnosed at 18, I had to get a medical diagnosis to get accommodations at college because my IEP wasn't valid anymore once I graduated high school, individualized education plan. And once I was diagnosed, I cried for like a day because I was like, I can't believe it's real. I can't believe I'm really able to stereotype here. And so, yeah, now I'm at the point where I'm like, autism is not good, it's not bad, it just is. And it has talents and its difficulties, but so does being human. And if I wasn't autistic, I don't think I'd be as good of a writer as I am. Writer, not writer. I don't write horses, I write poems. But I think that it also causes a lot of problems in my life. And that's just, it's okay. I don't think it should be cured because I don't think it can be cured. And to say it could be cured is like trying to cure homosexuality. Like, I'm gay, but I don't want to cure that, which is a whole other story. Or curing being a woman. It's just a part of who I am. And I think that takes a long time to understand. So did I answer your question? I don't know.
Yeah, absolutely. The reason I asked you was because I was relating, I don't have ASD, but just I was relating from my OCD journey so much to what you were saying about your ASD journey, some of the things that you were talking about. There were so many similarities talking about suicide or getting better. And there were so many similarities in my own journey. So all I could think about is you went through it twice in a way, you know, with first the OCD diagnosis and the ASD diagnosis, which breaks my heart. So that's why I was curious about that. Yes, you answered my question. I know Rebecca has a thought or two. Go ahead.
I wanted to ask a question. Oh,
sorry. The majority of autistic people prefer autistic or person on the spectrum versus person with autism.
Okay.
It's just a thing. I didn't mean to interrupt, Rebecca. I'm so sorry. But sorry. Yeah. Okay.
Yeah. Mary, I was curious for you, what has been the best resource of how you've learned about autism now that you're saying like you've been able to understand yourself better and feel like you've been able to ditch some of the ableistic thoughts about yourself? Where have you gotten good information from?
From other autistic people. There's a lot of autistic self-advocates who, a lot of them aren't able to communicate verbally, but can communicate in other ways through typing. I read a lot of essays. I read a lot of Tumblr blogs. Say what you will about Tumblr, but in 2015, it was a big deal. Actually, autistic hashtags. I kind of didn't read much at the time from medical textbooks and psychiatry textbooks because it was all autism is the medical language. But hearing other people have shared lived experience to me was really validating. And being like, okay, and also helping, working with other autistic people who are younger than I am. And being like, I can make a difference in this kid's life and have him not go through like the years of self-hatred that I did. And realize that autism is okay from an early age. And I think that really helped me feel okay. So yeah,
Thank you, Mary. I appreciate that. And just to piggyback on what Rebecca was saying, the IOCDF just posted some good resources and links down below, I think at the 731. Let me see here. Yeah.
Ethan, I'd like just to mention one thing, you know, that I want to build on with Mary is that I think one of the things that you were saying made me think of something, and of course I'll get Rebecca's thoughts on this too, is how the autism diagnosis is shared is so essential because it's just like, you know, if you know in advance that if you have a baby that might be that might be postpartum, or that this might be one of the issues that people go through hearing this, then you can be prepared for it, and a family can be prepared for it. And I think there's a wide range of ways that that diagnosis is shared with people. Sometimes it's shared with parents and not with the person. Sometimes it's said in a very blunt way, and sometimes it's something that becomes kind of a whole involved way, which I think is very important, of explanation. And this is what people could experience if you do experience this kind of sense of being broken. Then this is, it's common, but this is what we can do about it. And I think that's you touched on so many things in your comments that I'm so glad we're having this meeting because stigma is so important, to reduce the early identification, knowledgeable families, and creating a family structure where a person can thrive. All of those things are so important to. That's why we need to hear the voices of people with lived experience, just to highlight that these are essential issues and even life-saving issues to address.
Mm-hmm. Yeah, I was literally going to ask you the same thing, Jon. So thank you. You took it out of my. No, I was.
Well, at this point, I can read your mind, Ethan.
I know. I actually want to. If you don't have any more points, I'd like to. There's some great questions. I don't want to go too long, so let's just jump into questions. Actually, Jon, I'll throw this to you, but of course, Rebecca or Mary, feel free to weigh in as we go. At 7:07 p.m., Megan writes, "Can you self-diagnose as having high-functioning ASD? How important is a professional diagnosis? How valid is self-diagnosing for Asperger's or high-functioning ASD?" I'll throw that to Jon first.
Yeah, not only can you do that, so many people have never heard the diagnosis and actually do that they would say, well, either for themselves or a child or a family member, they'll say, hey, I read about this, I heard about this, or this is the feelings I'm having, and they explore it. So yes, I do. I also do at the same time feel it's very important to if you can, and of course it takes a lot of resources to do that sometimes, to actually have that professionally corroborated, because many things can look like other things. There was actually I think a very famous comedian in the last week who's suspected that they had ASD and turned out to have NVLD, and if those. That was a big story in the news, which inspired a lot of my patients with NVLD, actually, because they never see a celebrity talking about that.
Do you want to say what NVLD is, Jon?
Nonverbal learning disorder.
Okay.
And they do have some similarities, but some huge differences as well. But I can mention the person's name is in public, that Chris Rock was started speaking about this. And I think that's very important. And when people because for the person I was talking to, said, well, if that person could achieve this, then maybe my life isn't so limited. And I think it's very, very important to actually do what we're doing here, bring all of this into an open forum about that life. Diagnosis doesn't end life, it begins. It just begins like anything else, like how are you going to live the best life possible?
This is a good opportunity, Mary, to tee off. Sorry, Becca, 1 second. To tee off what we were talking about earlier, which was you found it incredibly beneficial to get diagnosed formally.
Yes.
Can you tell us a little bit about why that was so important for your journey?
I'm not sure formally is being aware of it and having a therapist really validate it, because, like I mentioned before the live stream started, I had like a dozen different therapists as a kid because everyone kept moving away or changing insurance. Is a hot mess. But like most of the therapists I had, except for the current one I have, who was amazing, everyone was like, oh, you can't be autistic, and leaving stereotypes behind. Having a therapist say, yeah, I think you're autistic, I think you should get diagnosed. And basically, she told me she thinks I'm autistic, but I'm pretty sure she knew because she's, yeah. But for me, hearing that was like, okay, there's a way. This is why ERP treatment can be difficult. It's difficult for everybody, but can be difficult in different ways for me. And this is why when I have to focus on something, it's not necessarily OCD. It can be I'm engaging in a special interest, which for me, I'm not going to talk about that because I will not be quiet. And follow my Twitter if you want to hear about it. But just hearing that, okay, it really helped my depression get better, because I'm like, oh, okay, this is not, I'm not broken, I'm not weak or defective. This is after all the self-acceptance and journeys, obviously. But knowing there was a reason for some of the stuff I did really helped me focus on my ERP treatment more, and really kind of lifted my depression. And guys probably all know it's hard to do ERP treatment anyway, but especially when you're depressed, because like, so.
I relate to that. Thank you, Mary. Rebecca, I know you had some thoughts.
Yeah, I just wanted to say, practically speaking, how important is a professional diagnosis? I think part of it also depends on age. If you have a child or you're a teenager out there, or even a tween, and you happen to be watching, when you're in school, legally, you're entitled to certain services as an autistic person. And I think that's where, for sure, having a professional diagnosis in order to be able to access those services and accommodations and resources is hugely important. Also, when people are going to college, they may find that there are some colleges that have better supports and better disability services for students. And then again, to be able to leverage and use and access those supports and services on different campuses may require a professional diagnosis. Those are two times where I would say, practically speaking. We also, I know a lot of people don't like to necessarily disclose their disability to an employer, but autism is protected under the ADA. And I have actually seen people who are very resistant to asking and disclosing with HR and for asking for any kind of accommodation during the pandemic. It's almost felt a little bit like necessary, and have said is the benefits outweigh the risks of like disclosing and understanding that it actually is their legal right to ask for certain things and to work with their employer. And again, sometimes having a professional diagnosis will help under those circumstances. So I'd say, practically speaking, those are the times where I'd say it really is helpful. But I don't think we can necessarily, outside of sort of the validation, always add any more information than people who are following that path to self-diagnosis.
No,
Sorry.
I'd like to just bring up something, because I just want to make sure we cover this, that OCD treatment, when there's autism, cannot be done in the same way as OCD treatment when there's not autism. And I thought that would be important. I don't know if there's questions about that, but I think it's very important, and not always easy to find practitioners who can kind of bridge both worlds, or that a team can be brought together where the both understandings come together, maybe in a team. Because if I just want to make this point so it goes out loud and clear, that OCD treatment needs to be very modified to be communicated to many people on the spectrum, and also to be effective for many people on the spectrum. So I just wanted to throw that as a conversation topic as well, and see if that's people's experience.
Yeah, one of the biggest things with that is, I would say, pacing and expectations of pacing. And I think once people realize that you just may have to slow down the pace with the dual diagnosis, that creates a shift for the patients, for the therapist, for the family, and people actually realize there is progress that's being made. So,
Again, I was literally about to ask that question. So thank you, Jon and Rebecca, for continuing to prove my genius. Don't laugh at me, Mary. So, no, I was kidding. I was being sarcastic. Yeah, no, don't mind me. Darcy at 7:09 p.m. If I don't call this question out, she knows where all my social media is and won't hurt me. Darcy asks, for Mary, what do you wish society people knew about OCD and ASD? You've answered a lot of amazing things, but if you had one thing, what would it be?
Darcy, I love you, but I hate you for asking this, because you're two good questions. But also, I love you, and I want to compulsively apologize now. Anyway, keep them separate. OCD and ASD, that you can have both diagnoses, or you can have OCD and also be autistic, and that autism really just like OCD isn't always hand washing. Autism isn't always unable to talk 3-year-old boy who loves trains, and just that autism is a varied experience. Like, I was talking to my mom today, like, I'm a published award-winning journalist who presents on panels and like holds on desks. I can't tie my shoes. Having a benefit in one area does not mean that, and does not mean you're lower functioning. Like, I say 99% of 22-year-olds can tie their shoes. I don't know how. I can't find motor skill work it out. but I can do all these other things. So realizing that just because someone may be lower functioning or non-speaking, which speaking has no correlation to, or not a very strong correlation to functioning. A lot of people I know, a lot of people who can speak, they fit in better neurotypical. Anyway, sorry. Just that it can be. There's a varied experience, and that to not just take people at the textbook definition. And I think people are getting better about that. And being like, okay, maybe you're not Rain Man or Sheldon Cooper, which are both white men, but maybe you're just different, and just realizing that there's more to them just stereotypes. So
I love that, Mary. I think that's incredibly powerful, and I appreciate that answer for sure. I want to quickly jump to Lynn's question at 7:10 p.m. How can I get teachers to understand that OCD is a real illness? It seems they don't know much about it. I just want to quickly say, because I want to move on, we'll put a link, anxietyintheclassroom.com. It's a great resource by the IOCDF addressing OCD in the classroom, how to talk to teachers, how to identify. We work very tirelessly to address a lot of these issues. We know in schools so often things are diagnosed as anxiety, depression, anxiety, depression, anxiety, depression. So we're working very hard. I don't know, Rebecca or John, if you have some quick comments on maybe some go-to.
I think it's great to have that that go-to for IOCDF, but also if it's possible in your area, I think you could find any number of practitioners who'd be willing to come in and do an in-service for the staff on that, and actually even go into the classroom, not identifying any particular person, and give a talk and help people understand that, you know, people have all these different things, including ASD, including OCD, and familiarize people, because knowledge is, you know, I don't want to be corny, but knowledge is power. And once people understand something, they're just more likely to notice it. Because I know every time I've done that someone will say, hey, I wasn't thinking, you know, after discussion, there's someone will say, you know what, there's someone in my classroom. You know what, I wasn't thinking of it this way before. So I think we can broaden the education of educators in this area very, very dramatically.
Yeah, I would say or you can even just request a meeting. It doesn't have to even be a school-wide in-service.
Yep.
If you're feeling that there's pushback and your child needs an immediate need, if your kid's in public school, you can definitely sort of like request it, and they should allow it for the Committee of Special Ed. You can call a team meeting. If you're in private school and you're paying private school tuition, I would encourage you even more to say is like, hey, this is important. The other thing is that I would say is, this is something that I've learned from working with autistic people, is a clear visual goes a really long way. Simple, concrete visual. So if you can very simply write like obsessions with a small like definition with an arrow, and then write compulsions or compulsive behavior, and list like 3 very specific compulsive behaviors that your child is most likely doing in the classroom. And then you can write sort of like typical response that my child gets. So maybe what ends up being like accommodation. And you can say like preferred response to address OCD. That may be something. A lot of times when I've worked with schools, they have more of an ABA model. They do a functional behavior analysis and then come up with a behavior plan. And they're often sort of like glossing over the concept of OCD, and don't really understand that sometimes you have to like reinforce a child for resisting or not giving certain kind of accommodations, which would be very different. So yeah.
And if nothing works, you can get an advocate, and
Yes.
for most schools there is a due process. And I think I certainly find when you reach an impasse, having a parent advocate, which most schools do have to provide you with, especially public schools, that in most states, that if you have an advocate assigned to you, you can educate them about it, and they can they can help advocate for you with the school.
Yeah, the last thing that I would add, that's excellent, John, is most school districts also have a SEPTA, which is a special education PTA. So you can find out who your SEPTA rep is and find out, maybe they can even, help you advocate about OCD. Yeah.
And if you have any questions specifically, you can always email the IOCDF at info@iocdf.org. We'll put the email up at the end, and we can discuss further. So thank you, John and Rebecca, for your insight. Actually, Rebecca, I'm going to throw this question out to you. Newt, I think it's Newt or not, at 7:10 p.m. asks, since both OCD and autism has this characteristic of obsessiveness, how would a clinician diagnose whether the person has OCD, autism, or both? It's a great question. I know we've touched on it a little bit.
Yeah, so I would say is in a couple different ways. I would say is for autism, it tends how I like to conceptualize it more is a fixation rather than an obsessiveness. I don't know if that's sort of just like linguistic parsing. What I would say is OCD also tends to be thematic. And some of the most typical themes of OCD are contamination, taboo thoughts, sort of like a morality or scrupulosity, a fear of harm, whether it be like magical or not magical, having also just right feeling. I'm probably forgetting about one or two, but I know that if you go to the IOCDF website, they do a good job about talking about typical content and specific themes. And I would say is most likely that's when we know we're in the realm of OCD and when something is actually an obsession. I would say when you're tending to find fixations, which often are things that the individual finds pleasurable or enjoyable or interesting, that's more like how Mary said, if we go to her Twitter, we'll find out what her fixations are. That's where more we would say is that's autism. A good example of sort of how to parse that out is I've had patients who, let's say, have a fixation on playing a certain video game. And I would say sort of that obsessive quality about the interest in the video game is more autism. But when they are not able to play their video game, or when they're worried, will I have enough time to play my video game? And they're repetitively asking, when are we going to get home? Will I have enough time? Will I have enough time? And even when a parent has answered, yes, we're going to be home by 7:10, and then you'll have a half an hour to play the video game, and they keep on asking, that is when it seems more, it's that asking for reassurance, that doubting disease that we know is far similar to OCD. So that's like sort of a quick answer to that.
Go ahead, John.
Sometimes people can get caught up in, is this OCD? I mean, sometimes it's an important question, but people can really go down a rabbit hole saying, is this OCD and is this autism? When in fact, they overlap so much. And in certain people, they're virtually indistinguishable, and one can even morph into the other. For example, someone can have a fixation, which over time becomes ritualized and resembles OCD more, and vice versa. So I would say that, for me anyway, that the most important thing is really, do you see, repetitive behaviors? Do you see things that are avoidant behaviors that just show fears, even if the person can't articulate the theme? And of course, that's one of the difficulties in talking to many people with autism, that they as Rebecca was saying, they have this just right experience, but they can't quite put it into words. And like, for example, if we give a standard instrument to assess OCD and a person has autism, we have to realize that because of the literality that Mary brought up, or because of communication issues, that scores may be relatively meaningless. Mm-hmm. And it takes some while. I like what Rebecca said about slowing the whole process down and really understanding that what's going on, because oftentimes, unfortunately, OCD goes undiagnosed because the person isn't reporting it in a typical way. They're not communicating about it. It just looks different. So I think finding people who are skilled, if you as a parent or family member or yourself really is feeling that this is what's going on, finding someone who's going to take the time to actually explore it in the depth that's necessary is very important.
Thanks, John. Let's stick with you for a second. At 7:11 p.m., Robert asked, can OCD cause paranoia, feeling of being watched when anxiety is high? Because I constantly think I'll develop psychosis or schizophrenia.
Well, yes. Being obsessional and being paranoid is, for some people, kind of not a big leap. Because, for example, if someone thinks something is contaminated, it doesn't take much to say, well, maybe someone is doing that. So sometimes, these things are just kind of evolutions and really still stay in the OCD realm, even if they can appear somewhat, very bizarre even, or unusual, or look like a thought disorder, can be OCD. But there are times when autism, OCD, and thought disorder, including paranoia or different kinds of delusions do cluster together.
Yeah.
And that's important to recognize as well. And also, I just want to emphasize, the earlier you spot these kinds of snowballing effects, the more likely they are to be treated effectively.
So, yeah, I would say two things to also keep in mind about this that we know is OCD can sometimes, we have the same thoughts as people with who don't have OCD. We either just have them at a higher frequency or they tend to be stickier. We tend to pay attention to them more. So in some ways, OCD is like a disorder of hypervigilance or vigilance, we can say. And so that can spill over to this idea of like, am I being watched? What we also know is OCD often causes us to do like odd behaviors in our rituals. And so I know if I was going around doing sort of odd looking behaviors, I might then start to be concerned. Are people watching me? What are people thinking about my odd behaviors? If there seems to be an additional flavor, one of the things that often helps with understanding is this maybe early stage of psychosis is one, looking at age. We know that psychosis tends to emerge in probably like late teens, early 20s. It can also happen at other points later in life. But that, and also looking at family history. So not necessarily dismissing it and saying it's just OCD, because we know if we can get people on the right medication, if it truly is emerging psychosis and have them understand it better, it can be transformative. But sort of looking at some additional variables with a professional to understand that. Yeah.
The problem in this area is there's lots of false negatives and false positives.
Yes.
Again, speaking to people who have a lot of expertise in this area, because people could appear to have a thought disorder when they really have OCD, and people could appear to more have OCD when actually it's a growing thought disorder.
Yeah.
So this whole area has sometimes people think that, oh well, it's this diagnosis, that diagnosis, and we'll do X, Y, and Z like it comes out of a cookbook. But actually, the more sophisticated a person can be in understanding all of these diagnoses in all of their different aspects, the better treatment can be tailored and personalized, and the more likely it'll be a good outcome.
Thank you. And Robert, I'm going to be an advocate for you and not your OCD, because you then followed up with, I've spoken to numerous therapists, all say it sounds like OCD when I don't agree with the paranoia feeling, it just scares me. So I will say that OCD will never be satisfied potentially with anyone's answer. So at a certain point, living with the uncertainty that it may or may not be and moving forward with treatment and modalities and values might be an excellent idea. But thank you for the question for sure. Mary, I'm going to throw this out to you. I think you're the perfect person to answer this question. Heather at 7:13 p.m. writes, how do you satisfy the need for routine in ASD when you are working against OCD compulsions rituals?
That's a good question. It might be not a good answer, but for me, the OCD compulsions feel different. Like I'm doing those because I feel anxious. I'm doing it to get rid of a bad feeling. I'm not supposed to do it, but I do. That's why I'm in therapy. Was another joke, sorry. But for autism, I don't know, I need routines so I don't get anxious. It helps me thrive and helps me function. Like I know that, interestingly, and this is pretty common from what I've heard, when I'm on weekends or long school breaks, like summer break or winter break, my OCD and my depression and my everything will get much worse. And I will not be able to mask my autism characteristics as well because I have higher anxiety. So I guess to answer your question, I'd really look at, with a therapist, if possible, really look at like what the routines are for. Like to use a stereotype, like flicking a light switch 5 times, is that to relieve an anxious feeling? Or is it because it helps like, I don't know, the words fail me and I'm a writer, it's bad. It helps like, you need it. I know it feels like you need OCD compulsions. That's the thing with OCD. But like when the pandemic first started and my school shut down and extended spring break by a week, I talked to my therapist on an appointment and I said, listen, I need something to do. So I made a 45 or 46 bullet point list of things I needed to do every day. And that got kind of obsessive because I don't do 46 things in a normal day, let alone there's a normal global pandemic and everyone's freaking out and I can't go anywhere. And so to sort of having expectations like, okay, I will do these things and I will eat the same thing for breakfast, as long as you're not like, I need to eat the same thing for breakfast or else I will get in a car crash later. So I don't know if that makes sense, but sort of like understand the motive behind them.
Yeah.
Like for me, OCD feels like I gotta do this or else.
You know, you're highlighting something so important, which it was experience. So how you're experiencing it is very important. Another thing that's very important is how it impacts functioning.
Yes.
If the routine is actually helping functioning, then fine. That's the difference between OC and the D part. That's the D in anything. If the routine is leading in the long run to interfering with functioning, then addressing it and actually using some of the CBT, ERP ideas would be the right thing to do, and refrain from getting the satisfaction because it's not helping you. That's what every behavior has to be looked at, is in the long run, is this moving your life forward or holding your life back?
Yeah. And I guess I'll add 5 cents in. But one of the things that we also look at in compulsions, or two of the things that we also look at in compulsions, is how time consuming are they and how much energy do you need to put into them, right? And so I would say is if something is a behavior that is either very time consuming or is really taking a lot of energy in order to get it accomplished, we can say it's a compulsion. It's not a functional routine. That's sort of an autistic routine. Like I know somebody, she's an autistic woman. She goes, she gets like a rotisserie chicken. She shreds it up. She adds some mayo. She adds some like apples and celery, and that's her dinner for the week. Like she just has a big bowl of it. And some people would say, oh, that seems like very ritualistic. Well, what it actually does is she doesn't have to worry about her dinner. She doesn't have to spend the time making it, and she's happy eating it. So it saves her time and saves her energy. And so I would say that's more of an autistic functional routine. The thing is, I think someone said, how do you satisfy the need for routine? If you're finding you're doing a functional routine, but you also know how OCD is this slippery little sucker and might try to take advantage of it, switch up that functional routine a little bit ever so often. Yes, you can still keep it a functional. Maybe she decides not to put red apples in and puts green apples in, or other things like that. Just to, again, play around with OCD to say is I can change it up and, not have to, so it doesn't feel like it could slip into a compulsion. Yeah.
So what you're saying is a lot of, obviously a lot more of the OCD actions, and I think Mary was hinting at this, are always to satisfy a discomfort or an uncomfortable feeling or just right feeling, when the ASD component is more functional, as you're saying. But still, okay.
It may or may not be. That's the tricky part that we want to emphasize. That just because it feels right or feels good or feels like part of your being doesn't necessarily mean it's going to help your being function in the world. Right. And that's it's important to pull apart those questions and look at them. Okay.
Thank you. I'm not going to post this because it's long, but it's a resource question. So for Jon or for anybody, my son has OCD, autism, and an intellectual disability with limited verbal communication. Because of the other challenges, OCD is often the last thing I can find treatment for. How do I find places that can help? His school is an ABA autism school. They do not understand OCD. I have not found a school that does both.
Are we able to know the location of the poster? Because we might just even know some people who are good clinicians.
Yeah, Andrea, if you want to, if you wouldn't mind saying where you're from, just go ahead and post it down below. I'll keep an eye out for it, and we can come back to your question. Go ahead.
Yeah, the other thing that I've had is a lot of parents can often be as smart, if not smarter, than us therapists. And I would say is if it's hard to find, I would say is find a good OCD therapist from the IOCDF directory and say, like, teach me about OCD. Download to me how I could become a good coach, and thinking about just even how parents can change accommodations that they're doing, or how they can change reassurance, how they can maybe tweak some of the things that they're doing, even in terms of like sensory accommodations versus sensory things that almost have like a compulsive quality to them. So yeah.
And also some of the clinicians that your son is dealing with may be willing to be trained. Later on, a comment was written by Mandy.
Yeah.
Thank you so much. Just completed the BTTI for my ASD clients to better serve them. Appreciate the info. So maybe just being able to provide resources for them might help. I'm looking down to see if they've commented yet. They have not. So we'll keep an eye out for your comment, but thank you, Rebecca. I appreciate it. Mandy asks, where can I, Mary, you brought this up before, so maybe you know. Mandy asks at 7:27 p.m., where can I read more about the mortality rates of those with ASD? I never heard that and would like to educate myself.
We posted 2 resources in the comment chat about that.
Okay.
There's also some, I don't think it's an American research article, but there's some other country research article they can find on Google. And there's like a bunch of, yes.
No, that's great. And yes, at 7:31 p.m., you will see the IOCDF and Peace of Mind posted Spectrum News news study identifies predicators early death among autistic people. You can check out that link. I think that's what Rebecca's referring to.
And that's been a really big change also, that years ago people would say, well, the suicide rate among people with OCD without ASD was fairly low. And we now know that that's a myth. So within that, there's another subset, which is that has a particular risk as well that was not well understood until recently. And that OCD and autism are synergistic, and the problems of one often inflame and feed off one another. So a person can feel hopeless, kind of a very deadly combination of hopeless and helpless and perfectionistic.
So to that point, Jon, about being synergistic, Annie at 7:47 wrote, what would you say, what advice would you give to a high schooler diagnosed with OCD but wondering about it actually being ASD?
Well, I think that's maybe time for a professional to help tease those apart, because that could be an obsession. I have certainly heard people with OCD having an obsession. Am I this or that? The same way, do I have this illness or not? Do I have this syndrome? And people read about it. But I think if at that point, if they think that, it might be important for treatment to actually determine whether this is something that you're going to do exposure for, like do exposure, and where if you treated someone with OCD who was worried about having autism, then there would be exposure exercises for it. But if they do, then it would be a different track. If they do are diagnosed, there would be a different track of understanding, education, and treatment.
Can I add something?
Of course, Mary, go ahead.
I would add that the professional who this person is consulting, would ideally be well-versed in autism as well as OCD, because I've seen a lot of, I don't think most of the therapists I've seen, if you ask them, hey, I'm worried, I'm autistic, they'd be like, oh, you're not autistic, you're a girl, or you can talk, or you graduated in 6th grade, or all this other stuff. And so have people who really understand maybe not the intricacies of autism, because a lot of people, even therapists, don't understand that, but just understand that autism can be broad and varied experience. Because I will say that autism is very underdiagnosed in girls and people of color. And so if you're in those communities, then I don't want to be talking about reassurance, but also a lot of times autism can be misdiagnosed as OCD. So I think finding a professional who understands both is really important.
And to that point, there is unfortunately a scarcity of therapists who fit into that category. Some of the things that's being done, and Rebecca is also co-chair of this, is the OCD ASD SIG at Special Interest Group at IOCDF. I think that's one of the major initiatives, is in terms of education, and through the Behavior Training Institute, the BTTI, the Behavior Therapy Training Institute that IOCDF has. They have in recent years really concentrating on training therapists, especially for the combination of ASD and OCD.
Yeah, the only other thing that I would add, along with the communities that Mary said tend to be underdiagnosed, I would also say people who tend to be highly verbal or also have a high IQ, especially when they're teenagers or young adults or adults, if they're also displaying, I would say, OCD-like behaviors, sometimes what they do is if they go for even a testing, which often the ADOS is considered the gold standard of testing for autism. A lot of times on the adult or teen module, if a person is highly verbal and has a above average IQ and has spent a life long, like sort of masking or social camouflaging, they may not ding on the ADOS and warrant a diagnosis. So you'll want to make sure that, again, if your son falls into that category, just make sure that the diagnostician has familiarity. I'm gonna send to the IOCDF an organization that specializes in working with people with Asperger's and high functioning autism, and they often have a nice Rolodex of therapists and testers in different states if someone really did want to get that as a rule out or understand that. So yeah.
I also want to mention that the subpopulation of people who are gifted intellectually have ASD and have OCD. Sometimes there's a myth that high intellectual functioning is going to rescue, and that's why there's so much. Sometimes if you have someone who's intellectually gifted, the families will just really concentrate on education and like that is going to offset the other issues. And unfortunately, I have to say that in many cases that is simply not true, and that the most important determinant is going to be social functioning for the long term. And it can actually be very cruel because people have a concept that by later teenage years or young adulthood years sometimes unravels to a point where it becomes a pretty bad situation, because it's very frustrating to say, hey, but you're so smart, which is certainly true, but that doesn't negate the potential impacts of autism and OCD on someone's ability to really proceed in the world, whether educationally or in a career.
I would even say
Jon.
adaptive living skills. So many of my college
that's
students,
the most important thing.
brilliant, get into great colleges, and academically they could pull the A's, but because they can't get themselves out of bed in the morning, they can't do their own laundry, just because there were skills deficits in that, and because of executive functioning also, they were never like properly taught and then reinforced as a necessary life skill. That can really junk things up even more than the, an IQ. Yeah.
So I want to thank you, Rebecca. I appreciate it. So I want to say a couple things, and then we'll get to a couple more questions and some last thoughts. First of all, Fran is doing a great job of keeping up with resources. Please, please, please go through the comment thread. There is a ton of amazing links and resources that are posted, from the resource that Rebecca just talked about to Anxiety in the Classroom and IOCDF and the article on mortality. So please take the time to go through if you're looking for resources. There's a ridiculous amount here. And also I'm going to tell Mary to go through the comments, because there's lots and lots and lots of love and support for everything that you're doing in your advocacy. So definitely take a moment after we're done to stay on and look through the comments, Mary, because there's lots of good stuff here about you. Heather at 7:50 p.m. I'm going to read this because it's going to cover the whole screen. I'll read it slowly. It's a two-part question. Is the only difference in treatment for OCD with AS-phobic panic disorder daughter just came out of a virtual 9-week PHP program for OCD, which actually made her compulsion so much worse. She's stepping down to IOP program tomorrow. How do we make sure they know what they are doing?
Well, that's a fantastic question.
Yeah.
I just want to keep emphasizing that the differences are, while pacing is important and the expected duration of treatment are important variables, there are so many more than that. There's how the concepts are explained to the person and to the family member. There's at one end, and generalization at the other end. How do you take what's learned in treatment and actually make it into life? There's how you're going to use more visual prompts and visual cues in a lot of cases. How you're going to actually not look as much for habituation or distress level, but for functionality. There is a whole gamut of different modifications that need to be made in OCD treatment for autistic people, that need to be strong considerations in designing a treatment plan.
Yeah. So one of the things I'm going to give a little self-promotion is with another therapist who has a YouTube series. It's My OCD Care, and I can see if I can do it in November, and you'll see what pre-pandemic Rebecca looks like in November. I gave a talk. It was mainly for professionals, but I tried to also make it a broad talk about how would you modify treatment? And so this might just be helpful for a parent to watch. I think if you're saying, how do we make sure they know what they're doing? I would ask very specific questions. One of the questions I would ask is, how many autistic patients have you worked with? What are the things that you find most challenging working with autistic patients? How do you work around those challenges? If you can identify like what you felt contributed to making your daughter's compulsions worse. If you know that, then like, again, ask them, I had this experience, how would you have done things differently? Some things that I would speculate probably had your daughter's compulsions worse is, if your daughter did some really big externalizing behaviors, and then by doing those externalizing behaviors, she was be able to get out of things. If she wasn't like given any distress tolerance, and emotional regulation skills along with it. If also people were using sort of more traditional ways of communicating, especially over Zoom, we're really relying more. Like I just had a session where I saw an autistic and anxiety patient have a really hard time. She started to shut down. We switched to chat. And I did like a good 7 minutes via chat, or like finger thumbs up, thumbs down. Those would be questions. How do you navigate when, you know, my daughter is starting to shut off verbally in a session? How would you navigate that? And other kind of like social communication deficits, how would you work around that? Yeah, I mean, those would be the things. My daughter doesn't seem very, very motivated to engage in exposures. How would you address that? And really like see, how satisfied are you with the answers? How easily do those answers come? If they come easily and you think like some of those answers make sense, then I would say, take the leap. Hopefully that's a good professional to work with. If you feel like they don't have good answers, then I would be a little cautious. Yeah.
And this is a good time to recognize, to just mention another variable, which is readiness for change. Oftentimes treatment is administered way ahead, and we could all fall into this because sometimes it's hard to tell, particularly if there's an issue in communicating about one's readiness for change, or you could ask someone because of literality about the readiness for change, and they could be responding just for that moment, but not in general how they feel about readiness for change. So and sometimes it is, in fairness, it is hard to tell. But one thing we do know is that if a person's readiness for change is low and the treatment gets too active too quickly, it is likely to result in worsening rather than improvements.
There's an expression.
Sorry, I'm just finding the link and it came up. Okay.
Mary, do you have any thoughts?
Because you guys did a great job. I like what Rebecca said about different forms of communication. Like I obviously can talk. I love to talk. I was not a late talker in speech therapy for a long time because it couldn't say half letters in the alphabet, but I've always loved to talk. But when I get overwhelmed, that's the first thing to go sometimes. I still can talk. In extreme situations, like extreme meltdowns, I'll be able to, we'll just repeat phrases like echolalia, which can also be a good thing, but it's a whole different thing. Echolalia is just like repeating bits of sentences or words or sounds. And for me, when I get overwhelmed, it's easier. Like my best friend is autistic. He lives across the country. So it's kind of, I don't see him regularly. And so when we're overwhelmed, we FaceTime and phone call and everything. But when we're overwhelmed, like it's easier just to text. One of my best examples of that is, even though I can talk, I prefer to text or type. And that's something I don't acknowledge very often because it's kind of taboo for like me to say, oh yeah, I prefer typing. But that's why I like writing, because I have time to like figure things out. It's my dog barking. And it takes less brain energy. So maybe if someone's getting overwhelmed, don't force them to talk. Sorry, I'm rambling, but yes, that and readiness for change is a big thing too. Sometimes people aren't ready, and what you said about being ready at that moment, be like, yeah, I'm ready to fight my OCD. I think people who are not autistic do say that too. But then when it comes to that, they're like, oh man, that's scary.
Right.
So yeah, thank you for bringing those up. This is awesome.
Another thing I want to bring up just for a moment is the different, one of the things that often impedes diagnosis or understanding at the, autism level is kind of the kind of mixing together and confusing social with social comprehension, just like reading and reading comprehension. Someone can love reading, can read words till the cows come home, but not actually understand the deeper nuances or have good comprehension of what they're reading and what a story is about. Oftentimes people, at least in my practice, people will say, well, they can't be autistic because they love people and they're around people, but we're not really talking about that, especially at certain levels of just general functioning. You can love being around people, but still not have a good theory of mind, not be able to understand the point of view of other people or pick up on nonverbal cues. And I hope that's okay. I just want to make sure that we have some of these very basic concepts to communicate to everybody about.
Thank you, Jon. And Heather, the last thing I'll say, and just in terms of make sure they know what they're doing, to Rebecca's point, is much like schools, it's okay to find an advocate for yourself. And, I know parents, especially with OCD too, they get into this guessing game where they try to figure everything out for themselves instead of even engaging an expert to help them suss out what they need to do. So for instance, if your daughter has been diagnosed with these things and maybe there's a therapist that you've worked with that can't accommodate the frequency and the level of care that your daughter needs, but has the knowledge that she needs, then maybe that therapist will help you, take the time to find the right place where that person or where your daughter needs to go. You can get creative like that and have advocates. We are wrapping up on time. I want to give everybody an opportunity to just give some last thoughts. I'll start with Jon. Any final thoughts, Jon?
Well, I just wanted to say how I want to thank you and thank Dr. Sachs and thank Mary for actually participating in this. This is not easy to do or taken for granted. I think it's so important that we all hear your voice. And one of the things that we have going on in these professional fields about OCD and therapy and even research is that it's very top down. That it's something that's done maybe to people or the experts are speaking. It's so important that communication go the other way just as much, and that we learn from the people who really are living this and experiencing this, what their needs are, what their concerns are, how we can better serve this community. So thank you so much.
Thanks, Jon. Rebecca.
I'm going to unmute myself because my daughter's making a lot of noise in the background. I don't really think for once, I don't have anything to really say, which is sort of shocking. This was like a pleasure. I thank the IOCDF for doing this. I thank the three of you for joining. I thank all the people for all the amazing questions and comments. Maybe I would also just say, I guess I do have something to say. I spoke too soon. Look, we're going through an incredible moment in history with the pandemic, and I think it's pushing buttons for both OCD and autism in very, very different ways, and especially with the combination. I think a lot of colleagues and I are seeing we're getting more and more people reaching out to us, and there clearly is suffering going on. I'm just so thankful that there are resources like this. I'm going to tell everyone out there, keep on reaching out to resources, keep on coming to things like that, keep on asking the questions, try to get as much support as you need. And also know this is not permanent. So if we're noticing our stress levels are higher right now, this isn't life forever. And I guess that's my message, my final comments. So.
Thank you, Rebecca. Mary, you get to end it all. What are your final thoughts?
It's a lot of pressure.
A ton of pressure. Go for it.
Yeah. One thing that I've meant to say the whole time, but my brain is a busy place and hyperactive. There's gonna be ADHD medicines worn off, so I'm like, ooh. But that just people talk a lot about social deficits and social deficits and neurotypical in communication. they don't realize that autistic people, we have our own way of communicating with each other and the world. So Adam's like, it may look like the things I do are weird, but to my autistic friends, it's just normal. And the things that you guys neurotypicals do, that's weird as hell. Like, I don't understand neurotypicals. It's confusing. I don't. I spent 22 years trying to understand and still haven't gotten it. But just that there's different. Basically, what I want to say is autism isn't bad. If your child just got diagnosed with autism, please work on just surround yourself with support and accept and listen to autistic adults. They have walked this path before you, and that autism and OCD is a tricky combination, but like you can do it. Like it's possible to get better from OCD. Like I was in residential treatment a year and a half ago, and now I like don't register on the Y box at all. So like that's pretty cool, and like you can get better even if you have artistic as well. And I just want to thank everyone for being on this panel. Being on a panel of PhDs is like, oh my god, like I'm someone who watches TikToks when I'm out in school. So thank you so much.
I feel the same way all the time, Mary, by the way, obviously, so thank you, Mary, and thank you, Jon, Rebecca, and Mary for joining. I'm going to end with the usual wrap up, but I want Fran to put this comment up just because this is exactly what we do. And Mary, this is a testament to what you do. Can you post Megan's comment at 8:25 p.m.? It was so nice to learn that I'm not the only one who has both OCD and ASD. For a while, I thought I was the only one. So it doesn't get better than that in terms of the reason why we do what we do. Mary, how important it is for you to continue to speak out and advocate so people know that they're not alone. So thank you, Megan, for that comment. We really, really appreciate that. Oh, and actually, Mary, Fran will post Mary's email. So perhaps that it would be okay, maybe Mary, if Megan emailed you.
I would love that. That'd be awesome.
Okay.
That's not a creepy. I'm sorry. That'd be cool.
Okay, so Megan, if you want to reach out to Mary, they just posted her email at strongerthanocd@gmail.com. You can email Mary. So thank you, Mary, and thank you, Megan. So quickly, just some quick wrap up. Thanks again to my guests, Jon, Rebecca, and Mary for joining us. As always, I want to thank the International OCD Foundation and Fran behind the scenes for doing his digital voodoo. If you haven't already and you want to be notified about all the programming the IOCDF is having over the next month, definitely be sure to subscribe and follow on Facebook and YouTube. I don't have YouTube written, but apparently we have YouTube and YouTube. You can also now check us out on Twitch. Twitch. Fran, you made me say Twitch because you were excited about the overlay. We're okay. You know what? Forget it. We're not doing Twitch. But you can find us on various modalities. You can also always check out the schedule at the IOCDF online calendar. We'll put a link to that so you can see all upcoming events. OCD Awareness Week is less than 2 weeks away, starting on the 10th. The virtual walk is coming up. We have lots and lots and lots and lots and lots and lots of amazing programming coming up. So check out the IOCDF website for that. We're really excited. Thanks again to everyone. So, and finally, again, any questions, comments, topics for the future. If you have questions for Jon or Rebecca, you can email the IOCDF at info@iocdf.org, and we will make sure to forward those questions to Rebecca and Jon and get your questions answered. Or if you need anything else, please never hesitate to email the IOCDF. So other than that, have a great evening. Stay safe, stay vigilant, feel the feels. Don't let OCD off the hook. And we will see you next week. Thanks again to everyone. Good night.
Thank you. Good night.